The food was great, and we're glad you enjoyed it. My counterpart, Claire Shipman, is a journalist and an author and a public speaker. She worked for CNN. She covered the White House, during the Clinton administration. She's co-authored 3 books, bestsellers, and you need to hear this, that she's a girl after my own heart. The Confidence Code, The Confidence Code for Girls, and Womenomics. Ladies and gentlemen, Claire Shipman.
You set the bar high, Deborah. I am nervous. We were over at our table thinking, all right, how are we going to make this kind of sexy, fun? We have the poster boy, we have the brilliant woman, all sorts of gossip, but I'm not going to go there. I'm going to take it down a notch. First, I want to say this is the kind of evening that makes me so proud to be a trustee of this university. I'm really honored to be here. It is, as I said to Wafaa, anything she asks for, I am here for her. We seem to be at an inflection point in terms of global health. There have been so many remarkable developments, as you've heard over the last 2 decades, especially in response to the HIV AIDS crisis, especially in terms of the prevention of the death of mothers and children around the world. It's also clear, I think, from everything that we've heard, that the achievements of ICAP and the achievements of Wafaa El-Sadr, and I think that we would not be here without Wafaa, are truly remarkable. I mean, it really is an incredible marrying of research and treatment on such a global scale that it's groundbreaking, and as Lee mentioned, it's really reorienting the way this university and maybe a lot of other universities will do business. So I really want everybody here in the room, I think you know it, but to know that we're celebrating something quite unique and powerful tonight, and thank you for being here. But I also want everybody to know that the jobs of battling HIV AIDS is not done, and of course there are many other health challenges that are threatening individuals around the world. We have an incredible all-star panel to talk about some of this tonight, and as I introduce them, I'm just going to have them wander up here so they can start to sit down. This is that awkward moment where people just come to stage. You 4, come on up. Because what I want to talk about with them is how can we take this framework that really ICAP has established, PEPFAR has established, all of the successes in HIV AIDS, and use it on some of these other global health issues and also in continuing the battle against AIDS. As I mentioned, we really could not be in a better position than to ask questions of the 4 people on this stage. I've thought of so many cliches in introducing them. They're on the front lines, they're the most brilliant, they're everything. They're also going to be really charismatic and outrageous and all of that other stuff that Deborah said tonight, no pressure. First, I want to introduce Ambassador Birx. She leads the United States' global effort to battle HIV AIDS. She has an enormous budget to do that, controls the PEPFAR budget for all of us, and is also the U.S. Special Representative for Global Health Diplomacy. A renowned physician and researcher, she's spent much of her life on this issue. There are also some good stories, I should say, by the way, from when Deborah and Tony worked together, but we won't. They're a little bit reminded me of Dr. House situation, but very funny. Dr. Anthony Fauci, another name you know, you've already heard his introduction, but he directs the National Institute of Allergy and Infectious Diseases at the National Institute of Health, the godfather of the NIH. He oversees an extensive research program there on infectious diseases, including on HIV/AIDS, and he has also spent an enormous part of his career on the HIV/AIDS issue. We're so thrilled to have with us tonight Rejoice Nkambule. Thank you so much for coming, Rejoice. She is the Deputy Director of Health Services for the Ministry of Health in the Kingdom of Eswatini, formerly Swaziland. And her country has literally been on the front lines of the HIV/AIDS epidemic with the highest rate in the world, some of the most difficult years imaginable, but things are starting to take a turn. Rejoice oversees the delivery of all the primary healthcare programs, including the HIV/AIDS in both community and hospital settings. And of course, Wafaa El-Sadr, the founder and global director of ICAP at Columbia University, an international expert in epidemiology and research on the prevention and management of HIV, TB, other infectious diseases, but generally just a remarkable human being and our hero. Thank you. Thank you. Thank you all. So, thank you all for being here. I'm going to have to go back and forth with my glasses, which is really frustrating. Ambassador Birx.
Yes.
You lead this incredible effort on behalf of the United States to confront the HIV epidemic, and it is one of the most complex epidemics in history. As we've heard, extraordinary progress has been made. Millions of lives saved, millions of new infections prevented. What do you think what have been the most important contributions in terms of a program like ICAP, PEPFAR? I mean, when you look at what has really worked, what has made the difference in terms of what we might then think about for the future?
Great. Well, I'm going to try to give you the Reader's Digest version of this, but I really want to recognize some of the other individuals who are here from universities, particularly Sten Vermont and Mike Cohen, because I want to take you back to 2003. So a lot of us were working in Africa. We were doing research on HIV vaccines or doing research on new drugs, funded often by the NIH. And in our communities that we were serving and doing research in the late 90s, the communities were literally dying by hundreds and then thousands. And we had lost a third of the parents, and we had child head of households. And when we get together as investigators, and we would have meetings, we would talk about this issue of the community dying despite the fact that we're doing $2 and $3 million research questions. And the majority, I would say 99% of the university investigators said that is not our problem. We're here to answer a scientific question. We're not here to take care of the communities. But there were some who stood up and went to the Elizabeth Glaser Foundation, and I want to really recognize Chip Lyons, who's here tonight, and got money to at least prevent the infection of the mother to child. Mm-hmm. It was a single dose nevirapine. That's all we had. But within months, all of us had 25,000, 30,000 mothers on this drug because we were so committed to that community. Then President Bush, based on the absolute guidance of Dr. Fauci, who believed we could go from no one on treatment to 2 million people on treatment without the infrastructure, because he had been out there and seen it and thought it could be done. Now, when a president does a presidential initiative, it sort of has to happen. So Dr. Fauci said it could happen, so we all believed him and President Bush. And there was ICAP and a few other universities who stood up and said, we'll help. We'll help. We have our research, but we're committed to the communities. And people like Wafaa put their research a little bit on the back burner, and Dr. Fauci was sympathetic to that, and helped stand up programs for where there was nothing, overnight there was something. Where there was despair, now there was hope. And that happened overnight. Now, there were university presidents who said, what about the liability of all of the people that we've got out there seeing clients, putting people on drugs? And some universities walked back and walked away out of that concern. So fast forward 5 years, ICAP was part of the absolutely key, what we call Track 1 partners. Of that 2,710, they were 25%. They had the 500,000 people on treatment that led to this great success. But then we came to them after this great success, and we said, well, we really appreciate everything you did, but now we want you to give up all the money, teach all of the people in those communities how to do this for themselves, and now we want to actually pay those community members and the local universities and the local clinics to do what you've been doing for the last 5 years. They stood up, and just out of sheer altruism, knowing they would lose the indirects, and the impact that that would have on the university, and the program that they had had for the last 5 years, they spent 3 years transferring 100% of those 500,000 patients onto care delivered by Indigenous partners who are today still delivering results at the highest level of quality. Now, at the same time, we found other things for ICAP to do and continued to fund them while I was at CDC. Now, fast forward again another 5 years. And we were doing this great work, and we said to ourselves, how can we really prove to the American people that that their taxpayer dollars that they gave us is having the outcomes and impacts that we say on paper we're having? And so we put out this solicitation for someone to do these surveys in the field, village by village, community by community, county by county, country by country, not one time, 13 times. And of course, because it was associated with me, I said, Wafaa, where are those results? We needed them 2 months ago. So I was up here with her team, and because of that, we know today precisely what our programs have done, where the gaps are, what we need to do, and we know precisely because of your taxpayer dollars and the involvement of ICAP that now incidence in Eswatini has dropped by 50% in Namibia, just in 5 years. This is what is possible. And I think when you say, what is that secret sauce? You had people of compassion and passion for others and a strong scientific mind that was willing to try to do new things, but collect data all along to figure out how to do it better, and built teams that were confident in their ability, and you can see that in the country directors you see today. And that is due to the team that Wafaa has created at headquarters. And I just want to really thank the president, because how you created and allowed people to thrive that were willing to give up your indirects, that were willing to serve others so that they could live and thrive and become their own academic in universities around the world. That takes, and not concerned about the liability and having to go to, you must have a great board of trustees. Yeah, a great board of trustees. But when you look around the United States now, there's a handful of universities who continue to do this work and are supported by their universities, and it's because of this that we have the progress we have today. 15 million people on treatment, nearly 14 right now. We hope to get to 15 million circumcisions. But now, instead of 500,000 babies every year born HIV positive, it's down to less than 100,000. And we know that because of this data. Wow. So it's huge.
It's huge. Well, so, like you said, you need brilliant leadership, altruism. And Dr. Fauci, this is also something you envision this in many ways, with the creation of PEPFAR. And when I was talking to Wafaa the other day about this discussion, and she said, Tony's really been focused on this mix for so long of evidence-based science and treatment, and taking it to where it's needed in a big way. Is this what you imagine, and what else would you add to the recipe? Do you have to be willing to break some rules? Do you have to be willing, what else has been important in this effort?
Well, you always have to break a few rules, but no, I think the point you made, Claire, is that when you want to do big things that have global impact, you really have to do it on the basis of solid scientific evidence. And that's, I think, the beauty of the marriage between the fundamental, basic, and clinical science, which led to our being able, Wafaa, Deb, and others, to be able to really articulate with a strong conviction that we actually have the tools to do the things that are seeing right now, transforming the lives of HIV-infected individuals. Some examples. First was drugs that you know save the lives of individuals. So the idea of saying we want to get drugs to people, there were always skeptics. Well, are they going to work? Will they be able to take them? You show the scientific data that's overwhelmingly positive that you can do that. So the next question is, if you treat somebody who's HIV infected, would you bring down the virus to below detectable level, and what would that mean in that person's likelihood or not of transmitting the infection to somebody else? And Mike Cohen, who's in the audience, led a study that to all of us in the field is one of the most transforming studies, because what it showed was that if you treat somebody who's HIV infected and bring down their virus to below detectable level, you make it essentially impossible for that person to transmit the infection to somebody else. And then we have something called pre-exposure prophylaxis, which people were skeptical about whether that would work, namely taking the bold step of taking someone who's at risk but not infected and giving them a pill, one a day, a pill that's 2 drugs, and determine would that prevent that person from acquiring HIV infection. And the answer is, if you take the pill, it's about 97% or more effective. So just think about this for a while when we've done the things we've done and asked for the resources to do PEPFAR and to do other programs, Wafaa's in particular. Theoretically, if you could access every person in the world who's HIV infected and put them on antiretroviral therapy to bring down their viral load to below detectable level, you could stop the HIV epidemic tomorrow if you could do that. So knowing that scientific basis gives us all of the ammunition in the world to say it would be crazy not to fund PEPFAR. It would be crazy not to fund Wafaa and her team. So the issue is, when you have solid science backing you, you're on very, very firm grounds. And that's what I call the interface between the pure scientific evidence and the implementation of the things that result from the science.
Rejoice, you have a lot to tell us tonight. You have a lot to tell us. Thank you for being here. Your country has had a real struggle, one of the highest rates, the highest rate of HIV/AIDS in the world. But recent studies I saw that funded by your government show that there's progress being made, that the rate is dropping. Can you tell us about how the infection what has the impact been, and how is your rollout of programs? How is ICAP, PEPFAR, how have those things helped the communities?
Thank you very much, and thank you for the opportunity to share our story. Allow me to start briefly to just highlight that HIV in the Kingdom of Eswatini was first diagnosed in 1986, and the first AIDS case in 1987. And that's when the national response to the epidemic started. And as normal, it was mainly raising awareness and just creating that awareness, and also struggling to understand how it is moving and how the magnitude, and trying to understand that. And the only measurement that was there was sentinel surveillance among the ANC. And we started that as a nation. And it showed that, as we tried to understand, it showed that it's increasing, the prevalence was increasing. For instance, between 1992 and 2004, the prevalence increased from 4% to 42.6% among the pregnant women. So that was quite a dramatic increase, and it really showed some great impact, because we began to see that it affects the economically active portion of the population. Parents began to die, and we got orphans that have lost one or both parents to HIV and AIDS. So it actually destabilized the social welfare pillar of the community. and we could see that AIDS mortality was increasing. And I think in 2006, Alan Whiteside, together with some of our people, did a study to try and map out the socio-economic impact of HIV and AIDS. This was a follow-up because he had done one earlier on, but now looking at what has the impact been and what does it look like in the future. And it highlighted demographic changes that were brought by that, and the wearing away of the human capital because of the deaths. And there was a significant burden on the healthcare system because there were a lot of people that were getting sick. And so it was becoming a problem. But one thing in that study that he concluded was that what will make a difference in how this continues is the provision and uptake of antiretroviral therapy. And that was very, very significant conclusion because it really gave the challenge to say, how does the country move forward? So in the backdrop of that, PEPFAR and the other global health initiatives, when they came into the kingdom, they found us a nation at war against HIV and AIDS. And this was through, led and directed by the head of state, His Majesty King Mswati III, and encouraging a collective action. And this political commitment was evidenced by actual financial commitment towards the fight against HIV and AIDS. Over and above the health budget, the country began allocating a budget towards antiretroviral therapy and antiretroviral drugs. And that commitment, I think, positioned us helpable because if a country can't face its own challenges, no one can come and assist because then you've not showed commitment. So that commitment, it positioned us. And when PEPFAR came to assist the country, I really want to point out that it made a significant difference. And why? Ambassador Birx has just talked that, being a performance-based grant, the PEPFAR support taught us how to use data, to look and interrogate your response. It brought in the element of performance not only into the utilization of the fund, but what is the fund utilized for? Yes, what makes the impact? What will bring a change to the epidemic? So those are the elements that came with the global health initiatives such as PEPFAR that are performance-based. And the second aspect that made a difference is the modality in which PEPFAR supports countries working through partners. That's how we got ICAP. And that's a very effective modality to countries and recipient countries because we then tap on the big network of this partner to get specific skills, effective partnership, and very, very targeted interventions. So we've been with ICAP, first coming as a treatment and support, a partner, but now I can say it's plus, plus, plus. I can't count all the support that ICAP is bringing into the country, but that's where our treatment and care programs took a leap. We saw decentralization of the ART treatment. We saw the use of nurses to initiate ART, all facilitating that treatment goes to the periphery where people are. And ICAP held our hand through and through that process because of the presence in country. And I must say, we really appreciate that support that ICAP brought and tapping on all the resource network and expertise that the ICAP family globally has, and we benefit in the country. I also want to point out this particular assistance that has made a lasting impact, the capacity for strategic information within the ministry that ICAP has helped us develop. Health research, we've grown. So we know now, quoting one phrase that Richard Horton, the editor-in-chief of Lancet, once said, it's unethical to take a policy decision without evidence. Through our partnership with ICAP, we've learned how to use evidence. We've developed in research, we've conducted the 2 incidence measurement surveys, we have had that capacity in the country, and we are growing in that. So we want to recognize that they've made us and they're making us ethical policymakers. So that's just been our story. This is just a highlight. I could take the whole evening.
Wow. Thank you, Joyce. Wafaa, that's incredible. What gave you the idea 15 years ago to start ICAP?
I think thinking back, I think it was a moment in history where myself and a few colleagues that are here in the room with me, we realized that it was an untenable situation. It was really a really global disgrace that here we had our fingertips discoveries and treatments that could save people's lives, and yet the millions who needed them could not get them. And I think it was maybe the anger, the rage, the sense that we have to prove those naysayers wrong that really drove us to say, yes, this can be done. And we can do it in partnership with the countries like Joyce was saying, and we can overcome all of the concerns that people had at that time. And there were substantial concerns at that time that this could not be done, that this was actually inadvisable even to try and do this. I think also another dimension for me personally was I had learned a lot by working at Harlem Hospital, at Harlem, as Deborah said. And also it was a similar community where people really didn't believe that the poor people of Harlem could take treatment, that they deserved treatment. And we did, and we tried very hard, and we did prove them wrong, all those naysayers. And I felt, and we felt strongly, that we could take some of those lessons learned, that we learned right here in this community in Harlem, can adapt and build the partnerships and make a difference and prove the naysayers wrong. So that was the genesis of the idea of trying to really bring this transformation. I really believe that HIV, as horrible an epidemic as it is and continues to be, offered a remarkable opportunity. It offered an opportunity to transform the health systems for the better. And it was a precious opportunity that we probably will never get again. And why is that the case? Because health systems in poor countries are usually tackling episodic. Somebody feels sick, they go to the clinic, they get a shot, they get a pill, end of story. Sometimes they find the pill, sometimes they run out of the pill, the labs are not there, there's no relationship that develops between the patient and the provider, and there's no relationship between the clinic and the community. And I felt from my Harlem years that HIV can create a transformation in the whole system because it is a chronic disease. Somebody who has HIV, there's no cure for HIV thus far, but that it requires a whole transformation. It requires the nurses and the doctors to realize that they have to develop a relationship with a human being for the long term. It requires that the laboratory be there to do the tests that are needed. It requires that the pharmacy have the drugs all the time, never run out. It requires that the data be there to know what people are doing. It requires that the staff are trained and work together as teams. For the first time, you had nurses sitting with doctors, with community health workers, all around trying to do one thing, and it is to preserve the lives of the people in their communities. And I think it was that sense, I believe, that HIV offered us the opportunity as a global community to have that impact. And that impact, I think that transformation will make the health systems be able to tackle whatever comes their way.
I'm so glad you brought that up, because I've wondered what the whether, and Ambassador Birx, I'll ask you, the framework that's been created now, say by PEPFAR and ICAP, how can that help with, not just continuing to battle AIDS, but other health concerns that might not be communicable diseases? What do you see out there? How do you think the framework can help? And in some cases, are we going to see what Wafaa is saying, that it may be that being able to design a system from the ground up will be more beneficial for some countries than the healthcare system that exists in some first world countries?
Yeah, I think that's the really exciting thing, and I think Rejoice captured it perfectly. And I just want to also call out Mrs. Melman, because when you think of establishing a public health institution at Columbia, I don't think anybody saw how those threads would connect to create the possibility that a university could provide that kind of intellectual but compassionate leadership around the world. So, when you start these things, you never know how many millions of lives now are saved around the globe. I mean, we saw the Central Asia piece. I mean, this kind of forethought that Columbia had to set up these institutions, so critical, because at the time, you think you're serving one thing, and in the end, you have this global reach that changes the future of whole countries. I mean, when you're losing 50% of your adults, you're losing your country. I mean, you're losing the very fabric of communities and nurses and doctors and teachers. I mean, it's just extraordinary. But this framework that Joyce just talked about, she talked about it wasn't just about serving the client, but understanding how to serve the client best. And when you know how to do that based on data that lets you see down to the client that you're serving, that's transformational, whether you're serving diabetes, hypertension, or any other future disease. That talent-based, what we didn't talk so much about is the reason we have, just over the last 5 years, in a flat budget, we've gone from just about 6.5 million people on treatment to 14 million. We've gone from 4 million circumcisions that protect young men from ever getting infected to 15 million, flat budget. How do you do that? You do that because working with governments who have the political will, use the data to target the resources where the need is. Now that may sound logical, but when you don't know where the need is, you put the same thing out everywhere. And so you don't know if you have 10 patients there or 2 patients there. So what happened in the early days, these precious drugs, they would all go equally to communities. And in some communities, there'd be no patients with HIV, and in some communities, there'd be 50. But you couldn't figure out where to move the drugs around. Now you know. You know where to put the medicine so that it gets used immediately. That kind of efficiency and effectiveness in a healthcare delivery system was created by PEPFAR and individuals, universities like ICAP. But countries now have taken that on as their philosophy of how to serve, whether it's sick children in a far province or mothers that have hemorrhage with deliveries. They now have the data, so they know where to train, where to have the drugs. That is the effectiveness that businesses brought to Starbucks. And it took us this time to figure out how to bring it to countries through a program like PEPFAR. That transparency, that accountability, it is what she talked about, that transformation of data to people that is allowing ministers of health with their limited resources to have a reach that they never had before.
And Dr. Fauci, Wafaa alluded to the, not yet the cure. Where are we on vaccine cure? Not to put you on the spot, but.
Yeah, Yogi Berra said it's always dangerous to predict, particularly about the future, right? Yes. So with regard to a vaccine, I'll get to, quote, a cure in a second. With regard to a vaccine, HIV is a very, very unique, complex, and complicated pathogen. Generally, when we make vaccines against anything, like right now we're making a vaccine for Ebola or for Zika, the premise of the vaccine is to have the body do what it does against natural infection. Because even though we have diseases like smallpox and polio and measles, in which there's a degree of morbidity and mortality, at the end of the day, most people recover from those infections and their body makes an immune response which clears the virus and protects you essentially forever against re-exposure to that microbe. That's absolutely not the case with HIV, because for reasons that are very complicated, the body does not like to make an adequate immune response against HIV. It just doesn't. It rarely makes good neutralizing antibodies, and by the time it does, the immune system is essentially shot. So the challenge of a vaccine is to essentially break the rules of infectious disease and create a vaccine that does even better than natural infection. Now, I'm giving you that introduction, Claire, because what it means is that it is unlikely that we are going to get a 98% effective vaccine the way we have for measles. If you get measles, you get a shot when you're 11 months old and then again when you're 4 to 6 years old, you're good to go for life. 98% effective. What we would like to have, if you have a combination of non-vaccine prevention, the things that Deb has spoken about, treatment as prevention, pre-exposure prophylaxis, circumcision, and combine that with something like a 50 to 60% effective vaccine, I think that's in the cards, and I think we will get that within several years. I mean, it's crazy to predict what year you will get it. But we have to get away from the idea that, like smallpox and like polio, once we get a vaccine for HIV, we're going to just prevent it. We're not. We're going to need the preventive measures that you've heard about this evening together with a vaccine. When you talk about cure, that's tough. Because if by cure you mean eradicate any vestige of the virus from the body, HIV is essentially the only human pathogen that integrates itself into the genome of a cell. And you put somebody on therapy, you suppress their viral load, they're great. Invariably, when you take them off therapy, the virus comes back. Now, to cure someone is to completely eradicate is going to be very, very difficult. So what we're trying to do is work on what we call ART, antiretroviral therapy, free remissions. In other words, to keep someone in remission without having to give a drug every single day of their lives. You can do that either with long-acting antiretroviral, you could do it by passive transfer of antibodies, or you could do it by things like therapeutic vaccination. So we have to be careful that cure itself might be more risky than giving somebody one pill a day for the rest of their lives.
Thank you. Rejoice. When you look at what your kingdom is dealing with now, given all of the successes you've had and all of the hardships, what other health issues are on your top 5 list? What are you thinking about beyond HIV/AIDS, and how important are they compared to what you're dealing with right now still with HIV/AIDS?
Of course, we have a number of issues that we need to be dealing with now. And in recognition that, when you have control or you manage how to respond to HIV and AIDS, you then become aware of the comorbidities. So non-communicable diseases, so it's an issue that we are tackling. And again, using the lessons we've learned in HIV and AIDS, first starting with integrating it into the HIV care, again, spearheading it through the support of ICAP, so that we see that people don't come many times. You come on this day for your heart treatment, and you come on that day for your diabetes treatment. So things that can be offered together. So we start there because we've learned in HIV/AIDS that integration works. And the other part we have seen in NCD is that there's no data. We do say we are seeing an increasing, but the data is weak to make effective and policy decisions. So we are improving on that and using the lessons in HIV and AIDS on how to improve data, make it talk to you at the front line so that you can be able to take those decisions. And so we are working on that. in the kingdom, amongst the NCDs, we have a high burden of cancer, and specifically cervical cancer, probably in the context of a high epidemic. So we've singled it out because, again, we've seen in HIV and AIDS sometimes you need to really focus on the highest burden and just build systems and be able to just have a grasp over that and control it, and then you're able to begin working on integration. Again, there we are using the lessons in HIV and AIDS, revitalizing our cancer registry so that we know exactly the data, and we begin to interrogate. You know, Ambassador Birx's approach to interrogating data challenges us as recipient countries, because you can't have a talk more about your data than you. So each time we begin to interrogate so that by the time PEPFAR says, through our partners ICAP, this is the situation, we have seen it and we are together in making the plan to go forward. So we are using that. I'll make another example of maternal health. Our indicators on maternal mortality ratio are not good. So we're challenging ourselves to say, what are we not doing right? Because we're doing well in PMTCT, and it is in the platform of MNCH. So we're beginning to see, to bring back what we used in HIV, that what cascade can we develop here? Let's use those things that we've learned in HIV. So we're busy on the table with that. And so we have seen that rolling out of HIV and AIDS, making it available, using, strengthening the health systems in the process, and interrogating the data to focus where it matters most. It has helped us to become a norm in our planning and our programming.
And do you feel like are you able to get the funds for these things, to identify them for maternal health? And is there more focus? Is there more commitment for overall health, given what you've been through?
Yes, there's increasing commitment, because we've seen that all partners, when you show cause that is evidence-based, there is no way that they would not listen and want to invest in seeing that difference. So that's what we've learned, and we are utilizing that.
And Wafaa, I want to let people in the audience ask a couple of questions, and I know we have to wrap, but I would love to know, Wafaa, when you look at other health issues out there beyond HIV/AIDS, what worries you? Where do you think the focus should be? Is it heart problems? Is it diabetes? What sorts of things do you look at?
Well, for starters, I think we should certainly recognize that we have not solved the problem of HIV. I think it's really important to acknowledge that probably only about half of the people who need treatment are getting it now. So we have a long way to go, and there are 2 million new infections every year. So there's a lot of work to continue that needs to be done to be able to get to where we want to get to really end AIDS and HIV as a global public health threat. So there's a lot of work ahead of us. And as Debbie was saying, there's through PEPFAR and other funders, a lot of work is being done to find efficiency so that to be able to actually scale up and increase. But there's a long way ahead of us to be able to get to where we want to get to, even just to tackle HIV alone. I do think that, though, I always say, and my colleagues at ICAP, we say that there's no need to reinvent the wheel. And as Rejoice was saying, I think that the looming threats are many, and certainly we've talked about the need to address tuberculosis, for example, another huge global health threat that comes together with HIV. And we should be able to tackle tuberculosis better by building on the HIV platform and by using some of the same tools. Certainly malaria in certain countries, particularly in Ethiopia, where we've been working for several years, there are tools that are fingertips, but again, they need to be scaled up, and it's happening, but it needs to be accelerated. And then there's a whole new frontier of non-communicable disease like heart disease, high blood pressure, diabetes, cancer. Those are the diseases that until now people have thought of them as diseases of the first world, but they're becoming diseases of countries, low and middle income countries as well. And Eswatini is beginning to tackle some of those, while at the same time having to deal with a huge HIV epidemic. And I think that the goal is, as we move forward, is not to reinvent the wheel, to take those lessons learned, the systems that are in place, and try to shape them, adapt them, to be able to tackle some of those new threats. And I hope you'll have a chance afterwards to go and look at the photographs around the room. There are photographs of the health system, of some of the work we do at ICAP, we support. And this is the work of the people we support in the field, the people at the health facilities and ministries of health. And these are the same people who are dealing with HIV, but they also are the same people who are dealing with all of these other health threats. So the investment in people, investment in systems, and whether they be laboratory systems or data systems or technologies or any other system is very fundamental, because I think ultimately it will benefit all of these and enable the countries to tackle all of these health threats. And it is kind of trying to learn from to take the lessons learned, to adapt them, to be nimble, use science, evidence, so that we don't waste resources, and be able to mobilize communities. I think ultimately what has made the HIV response successful has been the partnership with the affected communities everywhere, whether it be in this country or Eswatini or anywhere around the world. And we need to keep that in mind if we're going to tackle diabetes or hypertension or whatever it might be. We need to engage the communities. This is another important lesson learned.
Thank you, Wafaa. And I think we have time for a question or two. I see one right there.
Here.
No, you have a, no, you don't.
Oh, I do have a towel, thank you. So I just want to highlight something that is understated this evening, which is pre-ICAP. So if we roll the clock back to around year 2000, the Elizabeth Glaser Pediatric AIDS Foundation, with support from the Gates Foundation, launched something called Call to Action, which empowered many of us, and we were working in Zambia, to use nevirapine to prevent mother-to-child transmission. And two individuals, Wafaa El-Sadr and the late Dean Alan Rosenfield, had a vision that this was not enough. What was the logic of saving the life of an infant without saving the life of the mother and the father? And they formed a consortium of foundations. And let me just tell you, a foundation generally wants to get credit for its work, but nobody can tell you what the foundations were who supported the MTCT Plus, Maternal Child Transmission Plus initiative. And we saw this opportunity. We were just working in Zambia with our Zambian counterparts, and we saw this opportunity to establish model programs for family-centered HIV care. We immediately took advantage and were fortunate enough to get an award, which enabled us to establish model clinics for family-centered care. Why don't we save the lives of the parents, not just the lives of the infants? And that prepared us to be competitive and successful in our PEPFAR application in 2004, which we did, I was at the University of Alabama at Birmingham at the time, which we did in collaboration with the Elizabeth Glaser Pediatric AIDS Foundation. So we were what is often called PEPFAR 1.0, the pioneers of PEPFAR. We could not have been successful in that initiative if Wafaa and Alan had not had the vision to formulate, to forge the alliance with, I think it was, Wafaa, was it 5 different?
8 foundations.
8 foundations. And these foundations were willing to take anonymity. They were willing to simply join. That's how compelling Wafaa and Alan's vision was for them. And those of us who were in the field, this was immensely influential, because with the MTCT Plus initiative, we were able to figure out how to do family-centered HIV care properly so we could take advantage of the PEPFAR initiative in 2003 and 2004. So this is all pre-ICAP, and I wanted to dramatize it for you because it was it's invisible this evening what Wafaa's contribution and that of Elaine Abrams and Jessica Justman and the whole team of ICAP, because these were the pre-ICAP folks who contributed to this initiative. And just a little note of thanks also to my old mentor, Alan Rosenfield. Thank you.
Thank you. I think we do need to wrap. One person is taking a really late train back to Washington to keep working on the vaccine, and we don't want him to miss it. But I want to call Deborah in the red dress up because she's going to end this with a big bit of pizzazz. But thank you very much.